Okay, everyone, let's get started. Carol, do you mind transitioning to the next slide, please? Okay, everyone, welcome. My name is Jessica Gonzalez, and I am a coordinator with the Mental Health Technology Transfer Center Network, also known as the MHTTC Network. Thank you for your interest in our Intimate Partner Violence and Mental Health series that we have organized for you in collaboration with the National Center on Domestic Violence, Trauma, and Mental Health. Today's session focuses on intimate partner violence and mental health amidst the COVID-19 crisis and beyond. This is session 1 of 3 in the series. I want to quickly thank our lovely speakers from the NCDV TMH and our MHTTC colleagues who are supporting today's session. And a big thanks to all of you for joining us today. We truly hope that you find today's presentation helpful. Next slide, please. So we have made every attempt to make today's presentation secure. If we need to end the presentation unexpectedly, we will follow up using your registration information. A reminder that all attendees are muted and cannot share video. And if you have a question for the presenters, please use the Q&A pod. If you have a comment or a resource to share with all attendees, please use the chat box. The session recording and slide deck will be posted on our website within a few days. You will also receive an email following the presentation on how to access a certificate of attendance. And if you don't already, please do follow us on social media and stay in touch with us. Next slide, please. So for those who are new to the MHTTC network, the network accelerates the adoption and implementation of mental health related evidence-based practices across the nation. We develop and disseminate resources and provide free local and regional training and technical assistance for the mental health workforce. Next slide. So here is our lovely map displaying the centers that make up the MHTTC network. We have 10 regional centers, a national American Indian and Alaska Native Center, a national Hispanic and Latino center, and a network coordinating office. After this presentation, please visit our website and find your center so that you may stay up to date on trainings and resources that are offered in your region. Next slide. This webinar series is just one example of the training that we offer the mental health workforce, all free of cost. Next slide. This presentation was prepared for the MHTTC network under a cooperative agreement from the Substance Abuse and Mental Health Services Administration, also known as SAMHSA. The opinions expressed in the presentation are the views of our speakers and do not reflect the official position of the Department of Health and Human Services, or SAMHSA. Next slide, please. As part of receiving SAMHSA funding, we are required to submit data related to the quality of this event. So at the end of today's training, we ask that you please take a moment to complete a brief survey about today's session. Upon closing the webinar window, you will be automatically redirected to the survey. Next slide. Okay, now that we have that out of the way, we'll go ahead and get started. Next slide, please. It's my pleasure to introduce our presenters for today's session. We have Dr. Carol Warshaw, the Director of the National Center on Domestic Violence, Trauma, and Mental Health, and a faculty member in the Department of Psychiatry at the University of Illinois. She has been at the forefront of developing collaborative models and building system capacity to address the mental health, substance use, and advocacy concerns of survivors of domestic violence and other trauma. We also have Gabriela Zapata Alma, who is the Director of Policy and Practice on Domestic Violence and Substance Use at the National Center on Domestic Violence, Trauma, and Mental Health. She has over 15 years of experience supporting people impacted by violence, mental health conditions, substance use disorders, trauma, housing instability, and providing counseling, training, advocacy, and policy consultation. Carol and Gabriela, thank you so much for being with us today. I'll be passing it off to you now.
Heather. We're delighted to be partnering with you in this and doing the whole series on the intersection of domestic violence and mental health and trauma, and how to think about creating much more effective and survivor-defined approaches to addressing the mental health and trauma needs of survivors and their families. Let's see. Okay, so our center, the National Center on Domestic Violence, Trauma, and Mental Health, is funded also by the U.S. Department of Health and Human Services, the Administration on Children, Youth, and Families, and actually our direct funder is the Family Violence Prevention and Services Program, and we're one of 4 special issue resource centers, and ours is the one really dedicated to addressing these intersections of domestic violence, trauma, substance use, and mental health. And we provide a comprehensive array of training and technical assistance services and resources and consultation, research and evaluation, policy development, analysis, and public awareness. And we're part of what we're so thrilled about is partnering with the mental health training technology centers to really build collaboration across our fields. So we're delighted to be doing this with you. And this is the disclaimer from our funders. So just to start, we would start with a kind of framework for thinking about mental health in the context of domestic violence, and this is what we call it's ACRTI, Accessible, Culturally Responsive, and Trauma-Informed Approach. And historically, it came from when we started doing this work actually as a local project in Chicago in 1999, and then as a national center, there were a lot of challenges in even talking about mental health in the context of domestic violence. Partly, the DV field was very concerned in survivors about how mental health issues were used against them by abusive partners and by the systems where they sought help. And often the response from the mental health field was one of pathologizing and not really recognizing the social context that might lead people to develop symptoms. So when we started out, we were thinking about what we called a trauma social justice approach, or a trauma DV and trauma-informed approach that really held both the psychological effects of abuse and violence, but also the social conditions that produced it in the first place. So, our framework is kind of grounded in domestic violence and sexual violence advocacy, which is very much of an empowerment-based approach and consistent with a lot of recovery models now in the mental health field, grounded in a really deep understanding of culture, history, and historical and community context, and all the dimensions of people's lives that really impact who they are and what their options are and what their strengths and values and what's healing for them and what's not. A trauma-informed approach, which I think by now everyone is familiar with, but thinking of it in not just the traumatic effects of abuse, but also the social conditions, and very much grounded in a human rights and social justice approach. And some of the elements, I think many of you are probably familiar with SAMHSA's definition of what a trauma-informed approach is. And it's always hard to cram everything that's multidimensional into a small number of things that fit on a slide. But survivor-defined is really critical. And it's really, when you think about the impact of abuse and violence and the loss of choice and being controlled, that is really the antithesis of that. And that's at the heart of trauma-informed work as well. Thinking about emotional safety as well as physical safety. So depending what context you're in, one or the other might be prioritized, and they're both really critical. The importance of relationship and connection as part of a healing approach, and also the importance of hope and resilience. So that's, I think, there are many permutations of this, but that's a way of kind of bridging our thinking. The learning objectives, you can see we're going to talk a little bit about the impact of mental health on domestic violence on mental health, both pre-COVID and post-COVID. Some of the ways that the COVID-19 public health epidemic has created new safety risks for survivors and impacted access to resources and supports. And that's been real. I know that a lot of you have heard about the increase in domestic violence and the greater severity of domestic violence for people who are trapped at home with an abusive partner. So we'll be talking about some of the ways this is playing out and how that impacts service delivery. We're also going to talk about mental health coercion, which is, well, I'll talk about that in a minute, and some of the ways that you can listen for that as you're you're working with survivors in counseling or treatment. Some strategies for safely asking about IPV in the context of mental health services, including telehealth services, which both expand access but also increase risks, and how to link to domestic violence and sexual violence resources, which are going to be really critical as you start to take this on if you're not doing that already. Okay, so an overview of the mental health effects of domestic violence. So as you're probably familiar that domestic violence has, research has consistently demonstrated that domestic violence has significant mental health and substance use related effects and dramatic increases in PTSD, major depression, and self-harm, even higher rates of suicide attempts and suicidality among survivors of domestic violence, and then really even higher rates of substance use disorder among people who are victimized by an intimate partner. And when you look at the list of things, you can think about some of the risks for opioid use, including chronic pain, depression, trauma, insomnia that often, is a result of the trauma, but also abusive partners keeping survivors from sleeping. We also know there are high rates of domestic violence among people who are diagnosed with a serious mental illness, those studies in inpatient studies and community-based studies. We also know there are higher rates of depression, substance use among gay men, and increased rates of substance use associated with gender-based violence and gender-related abuse of transgender women. So the research is not as well developed, but it's emerging and something that we really want to pay attention to and follow. We also know, and for those of you who are working in mental health or substance use disorder treatment settings, that there are very high rates of DV among people seeking services. So very high rates of DV among women accessing substance use disorder treatment. And you can see 47 to 90% report lifetime abuse, DV, and 31 to 67% reporting DV in the past year. And we use that as a kind of proxy for probably ongoing or current exposure to domestic violence with people who are still at risk. And then there's a wide range. You can see there's a wide range because the studies use completely different definitions of substance use, definitions of DV, different settings. So over time, we're hoping to get better data, but from work we've done in the field and with our colleagues in substance use disorder treatment settings, people say that once people ask, and particularly about substance use coercion that I'll talk about in a minute, the rates are extraordinarily high. Same thing in mental health settings, over 30% of women in outpatient studies, and these are across studies. 33% of women in inpatient settings have reported current or past domestic violence, and then 30 to 60% of women in psychiatric ER settings report victimization by an intimate partner within the past year. So I just ask you to take a step back and think about the settings that you're working in and whether you're recognizing those rates of domestic violence in your settings, and if not, it may be that people aren't really asking or asking in ways that people feel safe responding. So just something to think about. The other thing that we talk about is that we know that survivors of intimate partner violence often experience multiple types of trauma across their lifespan, and so there's some data that earlier experiences of trauma place people at greater risk for future victimization by an intimate partner and by others. We also know that survivors experience multiple types of trauma, including collective historical and migration-related trauma. So when we used to think about definition of trauma and PTSD, we think about individual trauma like childhood abuse, sexual violence, intimate partner violence, and I think now we've been talking about this for a while. I think everyone is recognizing the social and political forms of abuse and violence and historical trauma that are also impacting the lives of everyone that we're working with. We also know when you think about the cumulative effects of gender-based violence, that also increases the risk for mental health and substance use disorder conditions. So there are lots of ways to slice this data, but we know that abuse and violence are all major sources of the both the development and exacerbation of mental health and substance use disorders and conditions. And again, discrimination, racism, homophobia, transphobia, historical trauma, deportation fears, I'm sure that many of you are seeing people who are experiencing that right now, also increase the risk. holding all of that in the work we're doing is really important, and it also impacts people's experiences of domestic violence and the forms that domestic violence takes. So given all that, hopefully those are things that many of you are familiar with already, but less so recognized and less so researched are the ways that people who abuse their partners engage in coercive tactics that are targeted specifically towards a partner's mental health or use of substances, that as part of a broader pattern of coercion and control. And we didn't have a slide with a definition of domestic violence, but it's really an ongoing pattern of coercion and control, and that all the forms of violence are in the service of controlling an intimate partner. So mental health and substance use coercion include a range of abusive tactics that are designed to undermine a partner's sanity and sobriety, control their ability to actively engage in treatment, sabotage their partner's recovery efforts, and then discredit them with potential sources of protection and support and jeopardize their custody, and then turn around and exploit a partner's mental health or substance use for personal or financial gain. So sit with that for a minute, and I'm going to show you the data slides from two surveys we did with the National Domestic Violence Hotline. Actually, we did them in 2012, and the reports from 2014 that were really eye-opening for many people who've seen this data. And it's the only quantitative data on about these issues. So the mental health coercion study was over 2,000 callers over a 6-week period to the national hotline who weren't in crisis but agreed to participate in the study because they wanted to help other people. 4 out of 5 said their partner had accused them of being crazy, crazy in quotes. 3 out of 4 said their partner, and it was like over 73% said their partner deliberately did things to make them feel like they were going crazy or losing their mind. And one of the things we've learned with I don't know how many are familiar with the tech forms of abuse of people who have the luxury of having a smart home, where an abusive partner might be doing things like turning up sound, locking the doors, turning the thermostat up to 100 degrees, doing things to make people feel like that whatever they said or did didn't happen. So that all of that gaslighting is very, very prominent form of abuse. And 1 and 2 said their partners threatened to report that they were crazy to keep them from getting something they wanted. The substance use coercion study, there was over 3,000 callers, and what we found was that 26% said that they had used substances as a way to reduce the pain of domestic violence, of the abuse by an intimate partner, but 27% said their partner had coerced or forced them into using substances or using more than they wanted to. 24% said they were afraid to call the police because their partner said that they would be arrested or they wouldn't be believed. And 38% said their partners had threatened to report their substance use to authorities to prevent them from getting something that they wanted or needed. So think about that we're very familiar with substance use as a form of self-medication in the presence of trauma, but thinking about how many people are initiated into using substances or forced to use by an intimate partner, something that people hadn't thought about as much before. And the other piece of this data that's really important is that abusive tactics often are targeted towards a person's attempt to seek assistance for mental health or substance use disorders. So in the mental health coercion study, half of the people who said they sought help for a mental health condition, for depression or for being distressed, that their partners tried to sabotage or prevent them from accessing that treatment or control their ability to access treatment. And in the substance use study, only 15% said they'd actually tried to reach out for substance use disorder treatment, but of those, 60% said their partners tried to prevent or discourage them from getting help. And one of the ways that happened, like they might withhold childcare or transportation, they might harass them out of treatment. Before it used to be through telephone calls, and now it's more through text. Or they may, people would come home from treatment and from inpatient treatment, and then they would have drugs around the house or have substances in the house. So anything that you could imagine a way to undermine someone's recovery, abusive partners would engage in that. And when we think about the specific forms of mental health coercion and treatment interference, there was a whole continuum of things that people did, like trying to influence diagnosis, trying to be in the session. You think someone has a concerned partner. You think about someone coming in, you get collateral information. Someone comes into an ER, and maybe it's someone who seems very concerned, but it's actually an abusive partner trying to control your perceptions of what's going on. We heard lots of stories of people who would force their partner to take an overdose and then try to have them committed, and if their partner didn't speak English, then they would completely control the perceptions of what was going on, or blaming the partner's mental health problems for the abuse. So it was their fault. I had to restrain them. We know that strangulation is one of the most lethal forms of abuse, and so she was out of control. I had to help her stay in control. And another way this plays out is control of medication. So there was a continuum of things that people who participated in the survey reported, like preventing a partner from taking their medication, forcing a partner to take too much medication or over-medicate or overdose, stealing their medication, calling their partner an addict for taking prescribed medication. So think about when you're actually working with someone and we're thinking about medication compliance or someone not taking medication. Are we thinking about what's going on within an intimate relationship that may be impacting their ability to take medication? One person reported their partner forcing them to take over medication, having them really sedated, maxing out their credit card while they were sedated and then leaving, or then having them be sedated and not able to function, and then not being able to carry out things that be able to participate, make a court hearing when there's a child custody case, or be able to go to work or participate in school. So ways that partners could use that to undermine their partner's ability to function in their lives and do things that are important and meaningful to them. So part of what we've learned from that is that experiencing a mental health or substance use disorder places people at a much greater risk for being controlled by an abusive partner. And this is further amplified in the context of COVID-19, where a partner may have actually more control, where someone may not be able to use their usual coping mechanisms, get away from their abusive partner, or engage in treatment. And one of the things that's really critical to hold in mind when we think about this is that the stigma that's associated with mental illness and substance use makes it possible for abusive partners to leverage the systems where survivors seek help. So if we've done a lot of work with family court judges who say, if they're seeing someone in a custody case or a child dependency case, and the abusive partner looks like they're in really good shape, and they're saying that their partner is, unable to parent because of a mental illness or because of substance use, that should be a red flag that there may be coercion going on. But judges are going to look at what they see in front of them. So actually educating those systems, if we're interacting with them, is a really critical part of this work. So to kind of pull this together, one of the ways that we think about intimate partner violence, and we're hoping that you will think with us about this in this way as well, is we're thinking about the traumatic effects of abuse and all the ways that can play out in someone's life, including economically and intergenerationally, but we're also thinking about the ongoing coercive control by an abusive partner that's actively undermining a person's sanity and sobriety and controlling their access to resources. Similarly, when we're thinking in a broader social context and thinking about the traumatic legacies of historical trauma, genocide, slavery, we're looking at all the multiple domains that people's lives are impacted that also impact their mental health and well-being. But we're also thinking about the ongoing structural violence and the policies and systems that perpetuate this violence and discrimination, so that there's always an activist component. So we're not just treating the effects of abuse and violence and discrimination and structural violence, but we're also working to change those conditions in whatever ways we can. So now I'm going to turn it over to you, Gabriella.
Thank you. Thank you so much. So now looking specifically at the impact of COVID-19 on access to services for survivors of intimate partner violence. And we'll also be talking about some things that we can do to respond to intimate partner violence when we do become aware of it, to safely respond and safely support survivors. Next. So looking at the impact of COVID-19, unsurprisingly, I don't think any of us will be shocked to know that IPV is becoming more frequent and more severe, that there is increases in the use of weapons and more severe injuries, and that this has a direct relation to the ability to isolate and exert power and control over survivors, over intimate partners. Some of this is related to being isolated from safe spaces that might be home, school, other kinds of services, friends, family, etc., as well as really being, and just think of being stuck with somebody who is abusive while sheltering at home and all the risks that that presents to well-being for ourselves and for our children. And so there are also additionally new COVID-specific types of abuse that are emerging. As Dr. Warshaw mentioned, people who use power and control over their partners will leverage anything they can in order to exert that power and control. So of course, with the emergence of COVID, there are COVID-specific types of abuse. Next. So here we have a flyer, which is very small, but we will make the link available in the follow-up FAQ. But this can spell out some of the different ways that COVID is being leveraged as a tool of power and control. So, for example, withholding necessary items such as things used to clean, soaps, hand sanitizers, using COVID-19 and potential risk as leverage to interfere with custody arrangements and keep children from their parents, as we know that abusive partners often try to interfere with the connection with the non-abusive parent. Survivors may fear entering shelter or might not be aware of what kinds of supports and services are available aside from or in addition to shelter, might not be aware of the kind of expanding resources available for safe shelter that also addresses the concerns related to potential spread of COVID. Next slide. And then we look at the potential impacts on mental health, including substance use, that we know that this is a time of increased stress for all of us, that many of us are grieving kind of a sense of normality, as well as grieving many kinds of complex and ongoing losses. And so here we see, of course, that really the compounded grief, stress, anxiety, fear, and really effects of trauma, what it means to be constantly trying to avoid any kind of abuse, of targeting, of victimization, while being really trapped with the very person who is abusive. And then unsurprisingly, increased substance use, as well as increased substance use coercion and increased mental health coercion. So somebody who may have been able to access mental health services without major interference by an abusive or controlling partner in the past, that might look really different in the face of COVID. Next. And so this is to really visualize all the complex barriers and threats to safety that survivors and their children face. And so all the multiple ways that abusive partners exert power and control related to survivors' mental health, including access to resources. And that really, while the people who are accountable for exerting power and control is the person themselves, right? Nobody else can control them or make those decisions for them. There are many things that we can do to help to support survivors in strategizing around their safety, as well as addressing stigma within our own system. Next slide. So enhancing safe access to mental health services for survivors in general, as well as amidst this crisis. Next slide. So first, building safety for survivors to talk about their experiences. Many times we've been trained to really, screen, assess, and then respond. And that when it comes to matters of trauma and when it comes to matters of domestic violence, the disclosure in and of itself can increase danger for survivors. So this raises a couple of important points. One is really focusing on building safety rather than focusing on trying to collect information. That when survivors know that when they have informed consent, when there's transparency, when there's confidentiality, when there's a sense of building trustworthy relationships and that emotional relational safety, they will disclose when and if it is safe for them to do so, and they are the ones who are the experts on knowing when and if it is safe for them to disclose what it is that they're experiencing. The other piece that this raises is being able to create access to domestic violence and sexual violence resources without forcing disclosure. So that these resources and information are freely available without somebody having to ask for them or having to say what is going on in their home or what's going on in their life. And then, of course, a really core component of this is accessible services and culturally responsive and gender responsive services. Next slide. So here is one way of approaching asking about domestic and sexual violence. So first, that confidentiality. Understanding that confidentiality is a safety need, that we do not ask these questions unless we already have confirmed that the person is that they're alone or that the person that they want present with them in their services is a safe person, and that we have also communicated the limits of confidentiality, that in some states and areas there may be mandated reporting of intimate partner violence, and that these can really increase danger for survivors. And so being fully aware of what those limits of confidentiality are and communicating them in a way that is clear and mutually understandable. And that if a person does not want to meet alone or declines meeting alone with us, then this is a time that we would not ask about domestic violence or sexual violence. It is not a safe time. We have not established that confidentiality. So with that confidentiality, then from there, we can take the stance of universal education and then empowerment-based approaches. So that rather than going on like a information finding mission, we're really providing general information and resources and creating space for somebody to share those experiences with us. That it's not, this is where our active listening skills become really important. Our engagement skills are exceptionally important. And that so that people understand that not only are we a safe person to talk to, but that we're a helpful person to talk to. That we actually know something about this and that disclosing this to us will result in there being, increased access to things that they define as being important, desired resources. And then ultimately, support. So that while it's not our goal to set out and try to just uncover this information from people, that when we set the foundation of safety and accessibility to information and resources, people will share their situations with us. And so being able to use things like harm reduction and offering safety strategies and making really those active service connections with specialists in domestic violence and sexual violence. Next slide. So some things to really kind of listen for and to potentially ask some follow-up questions when we are conducting an assessment. So for mental health coercion, here we want to listen for the relationship between how the person is feeling and potentially their symptoms to current abuse and the power and control behavior of people who they may be in intimate relationships with, and for people, it may not always be intimate relationships as we define it or as society defines it. So really, I often tend to just ask questions around who they tend to spend their time with, and really any of those folks may be people exerting power and control in this person's life, and many of the same skill sets and resources will apply. And then we can also listen for, if they identify an intimate partner, how does their intimate partner respond when they're experiencing mental health symptoms? Are they comforting? Are they supportive? Are they only comforting or supportive when they are experiencing more increased symptoms? What's the relationship between the symptoms and what's happening in their relationship and how they're being treated by their partner. And then also asking about how their partner might respond to if they're being prescribed medication or to their treatment plan, if they are sharing that with the information with their partner, what they think their partner's response might be. And that can help us also really listen for and really tune into any potential dynamics of power and control. Next slide. Some additional things to listen for: undermining in the relationship, blaming, so using both the labeling of, the diagnosing of partners or labeling of partners, using mental health words or derogatory words about mental health, as well as blaming the abuse on some, supposed mental health label, gaslighting, of course. Next slide. The jeopardizing. So listening for if a partner does anything that causes the symptoms to get worse, such as preventing from wellness routines, preventing from basic self-care like eating or sleeping, preventing or discouraging the person from accessing any kind of mental health support, controlling their use of medication or prescriptions. We also want to listen for discrediting, using the mental health condition to undermine or humiliate them with other people. This is a form of isolating somebody from any potential source of support. And then, of course, threatening to have somebody institutionalized or hospitalized, threatening someone that they would lose custody of their children because of something related to a mental health condition. Next slide. And then finally, to really be attuned to controlling, really listening for any attempts or tactics of control. And this can really come up particularly around any kind of mental health need or concern or service or resource. And many times, if we ask directly about abuse, people will really not identify with many of the labels. They won't identify with the label of domestic violence or victim or survivor. That can, for many people, for some people that can feel empowering, absolutely, and for some people it's just another label. But that when we describe or ask about someone's reactions to their mental health, their engagement in mental health care, that's where many times we start really hearing some of those pieces that indicate that there is some dynamics of domestic violence and power and control happening in this person's life. Next slide. And then, of course, beyond screening, making this information accessible. And so if you have services in person, this can be as simple as having information available where other brochures and information are kept. This can also mean that if with permission, we can send an information packet to the person's home or their secured mailing address, whatever they identify as a place where they can get secure mail. But then if we do that with their permission, of course, with their informed consent, that we provide a range of information and resources. That domestic violence and sexual violence resources is just one of many kinds of resources, so that it doesn't stand out and raise potential red flags and coercive control of the abusive partner. And then, of course, this takes staff being knowledgeable about intimate partner violence, as well as knowledgeable about the different resources that exist. Next slide. So now thinking about telehealth, as many of our services have passed over into the telehealth range. So while there has been a loosening of confidentiality and protections related to personal health information in order to create greater access during this crisis, that needs to be balanced with the safety concerns that for survivors, confidentiality is a safety concern, and that we will not always know. Frankly, many times we will have no idea that someone in our services is experiencing domestic violence. And so we need to take a universal precautions approach and really, as much as possible, strive to use secure methods of communication and address tech safety. And we have some different resources in the slides to help with that. And so, of course, the only person who can balance their needs between needing to access the mental health services that we offer and needing to protect their confidentiality and how that relates to their safety is the person for themselves. And so this is where transparency and informed consent and informed decision-making become really important. So that's really the role that we need to play, as well as striving to use the most secure methods possible. So some things that can help here is flexibility with appointment times and rescheduling. So if somebody misses an appointment, many times it's because it wasn't safe for them to attend that appointment at that time. And so any policies around only so many missed appointments and then someone has involuntarily closed the services, that is not consistent with being able to provide services for people who are experiencing intimate partner violence and/or sexual violence. Asking more yes or no questions at the beginning of telehealth sessions in order to establish that they are alone, that they're safe, that they have confidentiality, before diving into conversation where they would need to respond with more than just a yes or no response. People also have found it helpful to establish an individualized safety code word or phrase so the survivor can discreetly communicate that they can't talk right now, or they can discreetly communicate that they need help. Now, the important piece here to note is that this is individualized, and we also have had a previous discussion about what they want done in that moment, because it's not enough to just have a safety code. First of all, if it's universal, then that actually creates more danger for survivors, because that also means that abusive partners will know what the universal safety code word is. And then we need to know what the person would find helpful or what we can do to help in that moment if they do use that code. It might be something as simple as, you know, I'm going to pretend you're someone else and I'm going to call you later when it's safe, right? Or call me back when it's safe. Some people may want some form of, crisis support. And for other people, they're not going to want any kind of emergency system notified or formal crisis support system notified. And it's going to be more about notifying potentially a safe emergency contact or some other kind of follow-up action. So this is really important to build in before it's needed. And then, of course, like we always do in mental health services, using creativity around what is safe for the person, not assuming that we know what is safe for the person, but really building that together based on what they define as safe for them, and what is confidential for them to be able to have their session. Next slide. So then collaborating with domestic violence and sexual violence service systems. So as you've already gleaned, there are a lot of unique challenges that survivors face, and that DV and SV advocates are specialists when it comes to this. Specialists when it comes to safety planning, to navigating complex systems, including legal systems and court systems, housing needs, other kinds of resource needs, counteracting financial exploitation, navigating different medical responses to domestic violence and sexual violence. And so while it is important to be aware and cross-train, it's also exceptionally important to collaborate with the experts in these areas. Next slide. So important to note that just like mental health services, domestic violence and sexual violence programs continue to operate. We're still open. We're providing many virtual phone and video advocacy and counseling sessions in addition to in-person services, and many are beginning to expand their in-person services as different areas begin to reopen. Some communities are experiencing some reduced shelter capacity because of needs with distancing, physical distancing. But then there also have been some emergency funds made available to expand the use of hotels and private rentals in some areas and municipalities. If you find that this is not available in your area, it's certainly a point to advocate with local systems. Also, it's important to note that Many survivors of sexual assault who may want to have a sexual examination, a sexual assault examination, may really, rightfully so, have fears or concerns about going to a hospital in order to undergo that examination. And so some federally qualified health centers are now expanding their offerings in order to provide trauma-informed sexual assault examinations for survivors. So people who really know what's available in your community when it comes to this are sexual violence advocates. They know what different legal and medical options will be available in your community during this crisis. Of course, crisis lines are still operating and orders of protection are still available virtually. Next slide. I'm going to start to wrap this up so we can be sure to answer questions. Here's a list of resources so you can locate your local domestic violence and sexual violence coalitions. Next slide. As well as national domestic violence and sexual violence hotlines. Next slide. Next slide. And then we have a resource hub specific for COVID-19. And then here you see tech safety, next slide. And then here you see a tech safety and intimate partner violence, a digital services toolkit that really spells out what are some of the safest ways to use technology in communication when somebody is experiencing domestic violence. Next slide. And then another set of resources for intimate partner violence and COVID-19, including safety planning resources, including a smart device application. Next slide. And then, of course, it's the first in our series, so to be continued. We hope that you'll be able to join us for August 12th and September 9th. This was just kind of a taste, scratching the surface, and we'll be taking much deeper dives into these topics in the next two sessions. So now we can just kind of go through the rest of the slides, get social with us. It has our contact information, and we're going to go ahead and open it up for questions.
Thank you very much, Carol and Gabriela. This is great content, and we really do appreciate you sharing your expertise with us today. We do have several questions in the Q&A pod, and so we have about 12 minutes to get through those. I will let Heather Gotham, Director of the MHTTC Network Coordinating Office, lead us through our Q&A portion today. Welcome, Heather.
Thank you, Jessica. Thank you again, Carol and Gabriela. Lots of good questions in the chat and in the Q&A pod. I think the first one we would like to focus on, there were a few questions about safety cards. So if you could maybe speak a little bit more about safety cards, and also someone was concerned about the possibility of causing abusive retaliation by giving cards to the individual.
So the safety cards were developed by Futures Without Violence, and they have them for a whole range of different settings and communities. We partnered with them on one more around mental health and substance use. That's actually being updated, and their approach is to provide information that could be used by anyone, or pre-COVID, in a healthcare setting where you could have a conversation about what are healthy relationships and what are some of the things that you could do. So it's not just focused on domestic violence, or it could be if someone in your life may be experiencing this, you could have this and share it with them. So again, anytime someone takes something home that could be risky, we always ask about that at first. And these are mostly given out in healthcare settings where people have a conversation about whether it's safe to take them home. But it's an approach as well, which is really a universal education approach, and particularly in the context of telehealth services where you don't know what's happening at home, not starting to ask someone about DV when an abusive partner may be listening in. So it's providing information and going through some of the things that Gabriela was talking about, around with yes/no questions. So, and they're on the Futures website. So it's a way that they've kind of developed to approach engaging with people in conversations. I think when we started doing healthcare and domestic violence a long time ago, in order to fit into a more medical model, we talked about screening, which is like we've really moved away from because it's something you do to someone. It's like, how do you engage people in a conversation about the things that are happening in their lives that are meaningful to them? And as Gabriella, as you were talking about kind of weaving in questions about mental health coercion or listening for things rather than going through a whole screening checklist is a way to engage people in thinking with you as a partner about their lives. We've had colleagues who work in substance use treatment centers say that asking about, physical violence, people don't respond to very well, but asking about substance use coercion, almost everyone does. So it's just thinking about ways we can be engaging people.
Excellent, thank you. We've had a few questions asking about, do we have data on an uptick in IPV since COVID set in? I know there's certainly just reports of that kind of in general, but is there data and what are you seeing?
I actually haven't looked at data because we're mostly responding to what we're hearing from DV programs and advocates, and we were doing some work with the New York State Governor's Commission on, it had a task force on domestic violence. So we were hearing about, sometimes it was like going up, or then people weren't calling because they couldn't. And then after a while, there was a large uptick in calls and people actively wanting DV services or shelter or being able to be in a hotel. So, but big data, it's hard to, I don't think people have been collecting that. I mean, I think it'd be more hotline calls at this point.
What I've seen from different localities is more upticks in 911 calls, and then there being at first in the pandemic like a slight dip in hotline calls and seeking of services because it wasn't safe to seek services, and people were kind of trapped and under surveillance constantly. But then an uptick in 911 calls because then there was crisis, right? So then there being an uptick in that kind of like safety net crisis piece. But then as different locales have reopened, then having like a flood of people coming in for services now that things reopen a little bit more and they're able to get out of the house more.
Thank you. We've also had a few questions about migration trauma and immigrant communities. With COVID restrictions, it's hard to reach out to immigrant communities especially. Do you have suggestions about how to help survivors who are in immigrant communities?
Yeah, I think that first and foremost, one of the most helpful and important things we can do is connect with the, community leaders and connect with community members. And then see what we can offer and what we can do that would be helpful and relevant for them, and how we can collaborate and really enhance the what they already have in place. And that a lot of times things move by word of mouth. And so being able to really connect and plug into community is where then people are going to become a lot more aware of resources and then access those resources. Some of the things are really, really simple, like just language accessibility, that if there's not language accessibility, then it doesn't really matter how well our, outreach, how great our outreach is. And so having things really aware and upfront on the front end around language accessibility, so people don't have to like get through all the English and then get to our services to reach, service that's interpreted, et cetera. So that's one piece. And then another piece, sorry, my 5-year-old's trying to get in. And then migration trauma, there's a lot of resources I could share around this, but there is understanding first migration as trauma, and then the other piece is also understanding the different points in migration processes where there's high risk of trauma. So, pre-migration experiences, so all of the push factors of why people are leaving their country of origin, leaving really, everything they've known, right? That there's reasons why people are and these are known as the push factors. Then the traumatic experiences that can happen during the experience of migration, and then post-migration traumatic experiences, which can include processes of immigration and status, can also include experiences of discrimination and marginalization, and then also on top of all of that, being disconnected from one's cultural resources and one's community. So there's obviously a lot more there, and there's a lot more that we could share. So I'll be sure to include some of that in the follow-up FAQ and some links for further reading.
Also, we did a webinar with the Southwest Mental Health TTAC on, it was originally around trauma and immigrant survivors, but we were talking a lot more about COVID-specific experiences and people's fear of actually accessing resources because of fear of deportation, which was true before, and trying to, so the Texas Council on Family Violence, and I know lots of other DV programs and coalitions are doing work to try to, at the policy level, to make it, figure out what's safe and what's not, and to let people know what's safe and what's not, and to do the community outreach. So that's another place where those partnerships are going to be really important, because as clinicians, we're often doing services, but the DV field is often also doing community work and policy advocacy as well, and we'll be very knowledgeable about all of those layers.
Excellent. A question that I work a lot in co-occurring substance use and mental health disorders, and this question comes up a lot there as well as here. If you're working with a survivor who has a comorbid or co-occurring substance use or mental health disorder, which issue should an advocate or social worker address first? The substance use disorder or mental health disorder, or the domestic violence issue, or both? Or how do you prioritize or view those things?
I mean,
yeah,
Gabriella, do you want to speak to that first? Yeah.
Yeah, that's where having, that's where having a really integrated approach becomes so important, and having, whenever possible, integrated expertise. But if that's not possible or that resource isn't available, then having interdisciplinary collaboration and expertise, and that honestly we're all working together, and we start wherever the person feels like is the most pressing need and feels the most possible right now. You know, we might be seeing, as the external person to that person's life, we might be seeing, okay, this thing feels really important. It's like, it's really dangerous. We have to really address it. But that might not be what's actually the most important thing for that person in that time. And so that's where having the integrated approach, so that we can have the fluid flexibility to respond to the evolving needs of the person. And that's something that we can absolutely kind of stamp as being true, is that siloed and sequential approaches are not effective for folks.
And thinking about, like, when we even thinking about, trauma-informed, gender-responsive, culturally relevant approaches, where you're dealing, with all of the dimensions of who a person is and how they're managing whatever's going on in their lives. And at different points in time, one or the other may be the most, pressing for them, but that's why having an approach that can start where the person is so critical, and bring all the resources that they need. So thank you for asking that question. It's
I think we're moving to our last question before we wrap up for a minute. Do you have any experience or suggestions on outreach to the deaf and hard of hearing community, as English is not their first language?
There's a lot of work in the DV field on accessibility and partnering with organizations that specifically work with deaf and hard of hearing community. The Vera Institute has they're the TA provider for the Office on Violence Against Women Disability Grant Program, and they have wonderful resources for outreach. And we'll put that in the FAQs. I can't remember exactly the name of their website, but it's they've done a tremendous amount of work, and there's a lot of partnership and activism around that. One of the things that we were talking about recently is having ASL interpreters on webinars, as well as closed captioning. But I think just making sure that you have the technology and the ways to provide the services that people need, but also the partnerships with leaders in those communities.
Excellent, thank you. Great questions, Jessica.
Thank you so much, everyone.
Yeah, thank you. Those were all really great questions. I know that we didn't get to all of them, but we are at the top of the hour, so we're going to wrap this up. Thank you, everyone, for joining us today. It has been our pleasure bringing this session to all of you. Today's presentation slides and recording will be sent to everyone in a follow-up email over the next few days. We will also make these materials available on the MHTTC website. And I know since we didn't get to all of the questions today, we are going to be putting together a set of frequently asked questions based on the questions that were asked during the session today, and we will also be making that available to all of you in that follow-up email that we'll be sending out. Again, a reminder that this is only the first session of 3 in this series, and we have our next session coming up next month on August 12th at the same time as today, and we will focus on mental health treatment in the context of intimate partner violence. Information on how to register for the remaining sessions will be included in the follow-up email coming your way in a few days. Next slide. So again, we ask that you please take a moment to complete a very brief survey about today's training. You will all be redirected to our survey upon closing the Zoom webinar. We'll also be sending out that survey link in the follow-up email to everyone who attended. Thank you again for joining us today, everyone. Please take care of yourselves and enjoy the rest of your week. Thank you.